Thank you for joining today's virtual education program with Cancer Support Community Los Angeles. I'm Larissa Montalvo, and I welcome you to this week's webinar titled Dealing with Side Effects. Today, we'll be joined by Dr. Philip Chang to discuss the numerous sources of side effects from cancer, whether from chemotherapy, radiation therapy, or even from the medications used to treat the side effects of those treatments. Before I begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch past webinars, please visit our website at www.cancersupportla.org. Without further ado, I would like to welcome today's speaker. Dr. Philip Chang is a staff physician at the Samuel Oschin Comprehensive Cancer Institute at Cedars-Sinai. He completed a physical medicine and rehabilitation residency at SUNY Downstate, followed by a fellowship in hospice and palliative care at Montefiore Medical Center, and a fellowship in the emerging field of cancer rehabilitation at the University of Michigan. He has a special interest in the functional and symptomatic concerns of cancer survivors. He is board certified in physical medicine and rehabilitation and hospice and palliative care. Welcome, Dr. Chang.
All right, thank you everyone for joining for this webinar today, and thank you so much to Cancer Support LA for arranging for me to talk on this very important topic of dealing with side effects. I do not have any disclosures, but I do have a notice that this is intended to be for informational purposes only and should not be taken as individualized medical advice, and that a consultation with your medical providers is advised. So there are numerous side effects that can occur as a result of treatment with chemotherapy, immunotherapy, radiation, and surgery. And we're not going to really have time to discuss all those different things today, but we will be discussing kind of the more common side effects experienced by people listed here. So some of the general strategies that we're going to be going through as we talk about these different issues will include, number one, to kind of stop any medications that aren't needed or that aren't helping. As we all know, medications have side effects. And if a particular medication isn't doing what we want it to, but it is kind of causing other problems, and we want to make sure that we're kind of taking that medication away. Number two, we want to make sure that we're using non-medication treatment options when available and indicated, and that will include things like physical activity, which is a really big one that we're going to be discussing, physical modalities, psychosocial interventions, as well as activity and behavior modifications. And number three, we kind of do these other things and they're not working, then we will be looking to treat with medications that either have minimal or perhaps better tolerated side effects. Moving on to the first issue is diarrhea. So diarrhea is basically having loose or watery stools at a frequency typically of at least 3 times within a 24-hour period. And I know it's kind of weird to think about, but somebody actually made this chart showing the different consistencies of stools that can be passed. And this is called the Bristol stool chart. And kind of at the bottom here at type 7, we see that there's type 7 stool is entirely liquid with no solid pieces. But even if you're having kind of the type 5 and 6 stools, which are kind of softer and more mushy, these kinds of stools, if occurring again at a frequency of 3 times or more within a 24-hour period, would also be considered as diarrhea. So some of the common causes that diarrhea may occur include being on too many laxatives, the kind of diet that you may be on. For patients who have pancreatic insufficiency and aren't getting enough pancreatic enzymes, and severe constipation can actually masquerade as diarrhea. And the reason is because if you have kind of hard impacted stool, then the only thing that can flow around that is liquid stool. So in instances like that, the appropriate treatment would actually be alleviating the constipation. And then of course, diarrhea can occur as a side effect of both chemotherapy and radiation therapy. So shown here are a bunch of different kinds of laxatives that very commonly patients who are undergoing treatment for cancer may be on. And most oftentimes these laxatives are used kind of to prevent constipation that may occur due to use of opioid pain medications. While they are really good for that purpose, because they can be contributing potentially to diarrhea, we just have to be really careful that if maybe you get or have gotten an infusion recently and you feel that stools are starting to become more loose or more frequent, then we really want to be aware of stopping any kinds of laxatives that you may be on, as we don't want to contribute or accelerate the frequency of loose stools. In terms of activity and behavior modifications, it's important to avoid foods and products that may contain lactose, and it's also important to avoid any triggering foods, and that may include things like spicy foods. And in this regard, consultation with a registered dietitian can be really helpful in kind of discussing what kinds of foods would be best to take in and which ones to avoid. And really here, I can't really highlight this enough in maintaining adequate hydration throughout the process of having diarrhea, particularly if it's larger volumes of more liquid stool, as it's really easy to have your electrolytes depleted. So it's really important that you have a really good water intake whenever you are having loose stools. And if it's really severe, that you are in contact with your medical providers, as in certain instances, IV hydration may be indicated. So as far as medications and supplements that can be used, there are different kinds of bulk forming agents, typically in the form of pectin. And one type of that is Banatrol, which is shown here. And this is basically a powder that can be, that's made from banana flakes. And the way this works is it kind of helps to absorb water and give more mass and form to stool. Over the counter, there's things like bismuth, which is Pepto-Bismol, and loperamide, which is Imodium. Imodium is really kind of our main go-to medication for loose stools. And it's advised that you take 2 tablets after the first loose stool with an additional tablet after every subsequent loose stool. And you can take that up to 8 tablets per day. If diarrhea is continuing to occur, then you may want to talk to your physicians about starting on Lomotil. And this is basically a medication that works to kind of slow down the rate at which the gut is moving. Tincture of opium is another medication that can be tried that also works in a similar way of slowing down the gut. Although this is not always covered by insurance agencies. So that's something that you may want to check out beforehand. And kind of as we touched on earlier, in any cases where there may be pancreatic insufficiency, then you would want to ensure that there's adequate and appropriate intake of pancreatic enzymes. And again, I really can't overstate the importance of clinical nutrition and our registered dietitian colleagues, as they can be extremely useful in helping with these kinds of symptoms of having frequent loose stools. So moving on to the other end, we come to constipation. And this, of course, is having less frequent bowel movements, and it's typically considered to be less than having less than 3 bowel movements per week. So this will, of course, vary from individual to individual, as everyone has different kinds of patterns of regularity. But as we can see at the top of our stool chart, when you're constipated, your stool will kind of be smaller and harder and drier with these kinds of lumpy and bumpy formations. In general, the goal should be to have 1 bowel movement at least every other day. And there are certain circumstances, for example, for patients who might be on total parenteral nutrition, that they might have less frequent bowel movements, but generally for almost all of us, we should be really striving for 1 bowel movement at least every other day. And if you're someone who has increased frequency kind of at your baseline, then you want to be getting going as close to that baseline as possible, so we can kind of avoid the problems that constipation causes. So important factors in kind of mitigating constipation include our hydration level. So of course, kind of the more water we drink, the more water will go through our intestines and the more it'll hydrate stool and allow it to kind of pass more easily. And the majority of us really aren't getting adequate water intake. And, how much water you should be drinking really, varies based off of, the kind of diet you have, how hot it is outside, how active you are. So there's a lot of different factors that go into how much water you should be drinking. In general, I would say most of us should probably be getting somewhere between 50 and 60 ounces of water. But again, the point is we just want to make sure that we're getting an adequate level of hydration to ensure adequate hydration of stools. Mobility and maintaining good physical activity is really important, as the less mobile we are, the less functional our intestines will be. And the less they'll be pushing stuff out. So we want to make sure that we're physically active and moving around so that our intestines will also continue to contract. Our diet and making sure that we're getting a proper amount of fiber daily is really important for proper stool formation. And most of us should be getting somewhere around 20 to 30 grams of fiber per day, depending on your sex, and then the kinds of medications that we're taking can also play a pretty big role in constipation. So kind of the most frequent offenders that lead to constipation include opioid pain medications, so things like morphine, oxycodone, oxycontin, fentanyl, Dilaudid. All these medications play a really strong role in leading to constipation. Medications for nausea, particularly Zofran and ondansetron, can contribute to constipation. Some antidepressants, as well as some antihistamines like Benadryl, can all also contribute to constipation. So we just really want to be keeping in mind that all these medications are necessary and we need to be taking them at those doses. And if we don't need them, then let's not take them, and it may relieve some of these symptoms. In terms of activity and behavior modifications, as we stated, we want to maintain adequate hydration, have adequate fiber intake, and stay as mobile as possible. And another thing that we can do is make use of the gastrocolic reflex. So what is the gastrocolic reflex? So basically, this is a mechanism in your body by which your stomach can sense when food is being ingested. So when you eat, and food expands your stomach, then that activates stretch receptors that are in your stomach, and that basically tells your intestines to contract and start moving because there's more food coming down and we have to make room. So basically, we want to time our bowel movements to take advantage of this reflex, which occurs generally anywhere from like 15 to 60 minutes after we have a meal. So it can be useful to form a level of regularity of when we're having bowel movements daily, and to try to have a bowel movement after say breakfast or dinner at the same time every day to kind of take advantage of this gastrocolic reflex. And when we've kind of optimized all those things and they're not working, then a lot of times laxatives may be indicated, and these are all the different kinds of laxatives that can be used. So in my practice, I commonly will use a combination of a stimulant laxative, and a stimulant laxative basically promotes contraction of our bowels, and also an osmotic laxative. And osmotic laxatives work by basically drawing water into our intestines to kind of soften and loosen up any stools that are in there. So I'll usually combine these two. Colace is also really commonly used as a stool softener. I don't honestly use this one as much as the evidence behind it isn't great. However, everyone's different, and I have some patients who swear that this works really well for them. So I'm not against it. And if you're a person that this works well for, it's something that you can definitely try. And when constipation starts becoming more severe and you're getting to those 2-3 days without having a bowel movement, or 2, 3, 4 days without having a bowel movement, then may be prudent to kind of take a more aggressive course of action, in which case a suppository or possibly an enema may be indicated, and a lot of times these can be obtained over the counter. And for patients who are, not having bowel movement for, 4 or 5 days, I would recommend that you be contacting your medical providers, because at that point it may be indicated for possible manual disimpaction to occur, or possibly a larger volume enema. And then for those who kind of have more difficult to treat constipation, then there are also some prescription medications that can be used as well. So really, when we're thinking about diarrhea and constipation, it really is a balancing act of, we don't want to go too far on one end or the other, and we kind of want to stay in the middle of that Bristol stool chart. So it's really important to kind of keep all those different factors in mind, as well as knowing, when your infusion treatments are, and kind of how those affect you and for how many days they affect you. So you can kind of make a customized treatment plan of, which medications and which laxatives you should and shouldn't be taking at which times. So moving on here, our next topic is nausea. And there are a lot of different causes and contributing factors to nausea. And kind of, we were just talking about the stomach and intestines. And if you are constipated and you're all backed up, then that can also be a contributing factor to nausea. So again, really important to ensure that constipation is not occurring at the level of the mouth and the throat. For patients who are undergoing radiation therapy in that area, or maybe on certain kinds of chemotherapy or immunosuppressive medications, something that can commonly occur is thrush, which is a fungal infection, a white fungal infection of the mouth and throat area, which can contribute to nausea. If we have problems at the level of our inner ear, in our vestibular system, which is responsible for our sense of equilibrium and helping us to keep our balance, this can particularly cause nausea related to motions, like physical movement. And then finally, at the level of the brain, there's kind of two types of nausea that can occur. So one is what we call anticipatory nausea. So anticipatory nausea is basically when we become conditioned to feel nauseous in the anticipation of a certain event occurring. So kind of the most common example of that would be if somebody has their first cycle of chemotherapy and they have a very bad reaction to it with significant nausea and vomiting following it, then that can be a pretty traumatic experience. And our brains remember that. So the next time you go in for an infusion, your brain will kind of be telling your body, oh, I'm starting to feel nauseous again, even though you haven't gotten that infusion yet. So that's one way in which our brains can kind of contribute to nausea. And then kind of the more direct way is just the kind of direct effects of various chemotherapy agents working at different levels of the brain and brainstem to kind of trigger nausea more directly. So these are the different kinds of chemotherapy-induced nausea and vomiting. So there's acute nausea, which typically occurs within 24 hours of chemo, usually within 1 to 2 hours of infusion, peaking at 4 to 6 hours of getting infusion. There is then delayed induced nausea and vomiting, which occurs after 24 hours and typically subsides after 2 or 3 days. In some people, it can last a little bit longer, but for most people, it should really resolve within 5 days. There's an even smaller subset of people in which it may continue to persist for 7, 9 days afterwards. But really, if it's persisting longer than that, it would be best to kind of look for other causes other than the chemotherapy, as that's fairly uncommon. And then finally, there's the anticipatory nausea that we just talked about, where your body kind of becomes conditioned to feel nauseous prior to a specific event occurring. So how do we deal with this? So one of the non-pharmacologic methods of dealing with this is actually through acupressure. So there's actually pretty good evidence of acupressure working, particularly in breast cancer patients. And this is something that can be really easily done at any time whenever you're feeling nauseous. And the way in which we do this is kind of in this first picture that you see here. And I'm not sure if you can see me on the screen, but you basically put 3 fingers underneath your wrist crease. And then from that point underneath your 3rd finger, you should feel 2 tendons in the middle of your wrist. And you can apply pressure in between those 2 large tendons. And you want to massage that area generally for 1 to 2 minutes. And you can do this at any time when you're feeling nauseous. Of course, if you have any open cuts or wounds in that area, you wouldn't want to do this. If you have any lines that you're receiving infusions from in that area, you wouldn't want to do it, as well as any areas of redness or swelling. You would also want to avoid doing this, but otherwise, if your skin is intact and you're okay, then I highly recommend that you try this. This is a link to a website. It's Memorial Sloan Kettering Cancer Center in New York that has a video with more detailed instructions kind of demonstrating how to do this. But I recommend that everyone can give this a try. Of course, it is likely that for nausea, certain medications may be indicated if that's not, it's things like acupressure are not helping enough. So we kind of give medications based off of the area that's being affected. So again, if you're constipated and laxatives may be indicated, or if you're having kind of motility issues at the level of your stomach, then they might prescribe metoclopramide or Reglan. If your nausea is more induced by certain kinds of movements, or if you're experiencing vertigo, the medications like Benadryl and scopolamine patches can be helpful. If you're having the anticipatory nausea of, perhaps you feel nauseous before every doctor's visit or every infusion, then Ativan can actually be pretty helpful in treating that. And then for kind of the more directly mediated chemotherapy pathways of nausea, then there are a whole host of different medications that can be tried, and even combinations of these medications can often be used. So if that's necessary, I definitely recommend further more detailed discussion with your medical providers. So moving on, we are coming to cancer-related fatigue. So what is cancer-related fatigue and how is it different from normal fatigue? So in normal fatigue, it's proportional to our level of activity. So if we've been working really hard or we've had a really long day, then of course we'll kind of feel more tired. And when we go home to either go to sleep at night or to take a nap, then when we wake up, we should feel more refreshed and hopefully ready to take on a new day and more tasks. But cancer-related fatigue isn't like that. It doesn't matter how much we've been working. You'll just kind of continually feel tired. And when you go home and take that nap or go to bed at night, you don't feel relief when you wake up. You just kind of continue to feel tired. And this can be quite persistent and become severe to the point really of interfering with everyday activities. And it should be noted that this is incredibly common and is almost considered universal, affecting 100% of people when they are undergoing treatment for cancer. So what causes this? There's a lot of different kinds of contributing factors that are thought to thought to play a role. So one of those things is our circadian rhythms, which are responsible for keeping our internal biological clocks. So if those become disrupted, then we don't really know when it's day and light out, and of course that can affect our energy levels. Certain medications, frequent offenders being pain medications or muscle relaxants or medications for anxiety, can also contribute to feelings of exhaustion or being tired. Sleep disturbance for any reason, whether you have to go to the bathroom or you feel nauseous or you feel anxious, waking up at night and not getting a good night's rest will, of course, change the way that you feel. And cytokines also are thought to play a large role in cancer-related fatigue. So cytokines are basically small molecules that our bodies and cells use to give signals to other cells. And it's thought that in particular fat cells and some tumor cells may be secreting certain kinds of cytokines that contribute to a chronic low grade of inflammation that ultimately contributes to cancer-related fatigue. So fortunately, there are a number of different treatable factors that can be addressed to help mitigate the effects of fatigue. And some of those things are, as we're talking about, just treating the side effects of cancer treatment. So they've actually done studies where they follow patients and they're not specifically treating patients for their fatigue, but they're treating them for all their other side effects. So things like pain, coughing, nausea, poor appetite. In treating all those other side effects, their fatigue also gets better. Of course, treating symptoms like pain and emotional distress is important. If you're anemic, then something like a blood transfusion that your oncologist would order can be helpful if medically indicated. Of course, you would want to address the nutritional deficits, really limiting and mitigating any alcohol or substance abuse. Medications we kind of talked about and we'll kind of go more detail into, and then making sure that you're getting adequate levels of sleep. And then we're kind of also going to be talking about activity level here. Medications is a really big thing in fatigue. So polypharmacy, which is considered the use of 4 or more medications, is really common, not just among older adults, but among patients being treated for cancer. And a lot of the medications that we give contribute to fatigue and sedation. So again, frequent offenders are narcotic opioid pain medications, muscle relaxants, medications given for nerve pain. So that's things like gabapentin, Lyrica, Cymbalta, anti-nausea medications, as well as antihistamine medications. So we really want to be cognizant of how these medications are affecting us. And if we can reduce the dose, get a smaller dose of that medication, and still get all the positive effects, but try to limit the negative effects of the fatigue. And we also want to be concerned about the time of day in which we're taking certain medications. So Cymbalta, for example, or also called duloxetine, is a medication that's often given for mood as an antidepressant or for nerve-related pain. And this medication actually can have 2 different side effects in people. In some people, it can cause insomnia and difficulty sleeping. In other people, it can make them drowsy. So, the time of day at which you take that medication is really important. If you're someone that it makes drowsy, then, you would want to take it at night. But if you're someone that it causes difficulty sleeping for and it keeps you awake, then you would want to take it in the morning. So just being really aware of, how medications affect you and trying to take advantage of when you're using those medications. And, finally, this is kind of a theme, but if you can get rid of any medications that aren't needed or are no longer indicated, then you want to get rid of those medications again, so we don't have to deal with the side effects of those medications. So physical activity and exercise is a really important, perhaps even the most important tool in mitigating cancer-related fatigue. And I wrote category 1 here, and what category 1 means is that it's based off of, there was an expert panel who was just looking specifically into cancer-related fatigue, and there was uniform consensus among that expert panel based off of high levels of high-quality evidence that this is a very useful thing in helping to combat fatigue. So what kind of exercise are we going for? Specifically, we want 150 minutes per week of moderate intensity aerobic exercise. Okay, so yeah, that's great. What is moderate intensity? So basically, you want to be going to the point where you feel like you're doing something, you kind of feel like you're exercising, but you can still carry on a conversation. So basically, you should be working out to the point where you can talk, but not sing. And in addition to that, if you're able to, then 2 to 3 days per week of strength training, along with the aerobic exercise, has been shown to confer a number of benefits, not just with fatigue, but with many other things as well. So here, you can kind of see that it's also been shown to help with mood symptoms like anxiety and depression, as well as physical function and health-related quality of life. And again, there's really strong evidence that physical activity with 150 minutes per week of aerobic exercise and 2 days a week of strength training can really confer all these benefits. Of course, if you are in certain situations where you may be at like a fall risk or have like a rapidly deteriorating state, then you may want to talk to your medical providers before engaging in a therapeutic exercise program. But for those who don't have any significant contraindications, then yeah, physical activity is something that can really help with a variety of different things. So other non-medication-based treatments that can help with fatigue include psychosocial interventions. So this actually, believe it or not, includes things like being a part of support groups like Cancer Support LA, or engaging in supportive expressive therapies like journaling. And these things, I don't know how it works, I don't know why it works, but there's a high category 1 level evidence that those kinds of activities can actually help in mitigating fatigue. A massage actually has really good evidence supporting its use in helping with fatigue. And again, with everything going on with COVID right now, I can't recommend necessarily for people to go out there and get a massage, but if under some circumstances you can do this under safe conditions, this can be helpful. Other non-pharmacologic methods with a little bit lower levels of evidence, but still showing some benefit, include things like energy conservation. And this is things like, being aware that you have a limited amount of energy and kind of prioritizing which tasks you need to do, as well as delaying which tasks you don't need to do, and delegating tasks and asking for help when needed. Acupuncture, for those who have finished treatment, has been shown to be beneficial, as well as bright white light therapy. Bright white light therapy is exactly what it sounds like, where you basically buy like a really bright light, and you can get them off Amazon for like $30 or $50. You just type in bright white light. And basically, this is something you want to do in the morning, like when you first wake up. And you would just you just kind of sit in front of the light and let it shine on you. You don't have to look directly into it, but you just kind of look straight forward. And you just let it shine on you for 30 to 90 minutes in the morning when you wake up. And this has also been shown to have some benefit for fatigue. So moving on to a somewhat related topic is difficulty sleeping. So sleep disturbances are really common, occurring at a rate of 30 to 75% in people with cancer. And again, there's a large variety of reasons why someone may have difficulty sleeping. So it's really important to, if there is an identifiable root cause, such as anxiety or pain or having nausea, then you really want to be addressing that specific thing to kind of restore sleep back to normal levels. So one of those things listed there was hygiene. So what is sleep hygiene? So sleep hygiene is basically your habits of how you sleep and kind of what you do before sleep. So an example of bad sleep hygiene would be things like having a lot of daytime naps, consuming caffeine, alcohol, or high sugar foods before bedtime, using your computer or cell phone before bed, or even worse, taking your cell phone or computer in bed with you and using it in bed, watching TV or playing games before bed, and also having a poor sleep environment, meaning things like having a lot of ambient lights present, or having a lot of ambient noise. So then what is good sleep hygiene? So it's kind of the opposite of all those things. So we want to be sleeping in a dark and quiet room, and we want to be replacing any stimulating activities with stress reducing activities prior to bedtime, including things like reading, journaling, meditation, or yoga. If you've kind of optimized all these things and can't find any other identifiable root causes for having difficulty sleep, really the next thing I would recommend is cognitive-based therapy. So cognitive-based therapy is basically the process of identifying maladaptive patterns in our sleep and replacing them with helpful techniques. So there's a couple of applications that can supply this kind of cognitive-based therapy. One of them is Sleepio, which has a website, and they have a pretty good user interface, but I believe there's subscription costs. The one that I frequently advise patients to use is CBT iCoach, which is free and available on app stores, either on your iPhone or your smartphone. And it's something that you can just download really easily. And it has a lot of research behind it. It was actually developed by the Department of Defense in conjunction with Stanford University. I would just advise that you just download the app, and then when you open it, the first thing here is learn, and you could just learn about sleep hygiene kind of in more detail, and kinds of the different things that affect our sleep. So this is something that I would highly recommend to anybody who is having difficulty sleeping. And then finally, if needed, there are medications that can be used. Kind of my first go-to if somebody hasn't tried it before is melatonin, because it's something natural that our bodies just kind of make on their own. And, you know, you could start at lower doses between 1 to 5 milligrams at bedtime, and available over the counter. So it's really easy to get. For those who have kind of tried all these things and optimized their sleep hygiene, but we're still having difficulty, there are multiple different medications that can be used. Some that work really well are Remeron and Trazodone, and benzodiazepines are also commonly used to help with sleep if needed. But again, I would really defer to kind of using those non-pharmacologic treatments first, as we've kind of been discussing. You know, adding more medications adds the potential for other additional side effects. Moving on, I do want to touch on muscle and joint pains from aromatase inhibitor therapy, also known as AIMS, just because this is such a common issue affecting people with breast cancer. AIMS is basically pain and stiffness that occurs in the joints for people who are on aromatase inhibitor therapy. And it's really common, affecting up to 50 to 82% of individuals. And the aromatase inhibitors that we use in the States include anastrozole, exemestane, and letrozole. So why does this happen? The short answer is that we don't know, but it's believed that one of the possible mechanisms could be that estrogen decreases the pain threshold, just meaning that when you take estrogen away, you may just be more sensitive to feeling pain. Another thought is that estrogen may be protective to cartilage, which lines all of our joints. So when that cartilage is taken, or when the estrogen is taken away, that cartilage is more prone to damage and inflammation. But the fact of the matter is that we don't know. These joint stiffness and joint pain symptoms can really affect any joint in the body, but kind of the most frequent sites that are affected tend to be the hands, the knees, the feet, as well as the lower back. Symptoms will typically start 6 to 8 weeks after starting on an aromatase inhibitor. If you stop that aromatase inhibitor or rotate to a different one that doesn't cause these symptoms, then you should notice relief of those kinds of symptoms 2 to 4 weeks after stopping the offending aromatase inhibitor. So how we treat this really depends on how widespread the symptoms are. Really the most common area that I see patients being affected with this is at the level of the hands and the wrist. And if it's just the hands and the wrists that are being affected, then we can just kind of treat those sites specifically. And we do things like bracing or referring patients to occupational therapy. For more refractory cases, we can trial steroid injections, which can actually be really, really useful in helping to mitigate these effects. But if patients are having more widespread symptoms, and it's like every joint in your body you feel like is being affected by this, then really a combination of both exercise and medications is indicated, with the best evidence being for duloxetine. I do want to note that if you're on tamoxifen, you should not be using duloxetine, as it's been shown to affect the amount of tamoxifen that's actually present in your body. So this is a study, very good study that they did on testing duloxetine versus placebo in patients experiencing these kinds of symptoms. And they found, of course, that patients who were on the medication had lower levels of joint pain than those who were on placebo. For those who do have symptoms limited to the level of the hand or the wrist, and oftentimes this can manifest as carpal tunnel syndrome, then we would often prescribe a neutral hand splint depicted here. For those having tendon problems, which usually causes pain right about here on the thumb side of your wrist, we prescribe thumb spica splints, which can be very helpful. And for those who aren't kind of responding to those things, then we can do injections both for at the level of the carpal tunnel and at the level of the tendon, which again can be extremely effective in relieving pain at those sites. This is another study that they did showing the benefits of exercise. So again, throughout this entire thing, we're just seeing that exercise and physical activity can just help with a variety of different things. But again, one of those things is these joint pains and this joint stiffness. So they just did a test in over 100 women, and they split them up into two groups. One was assigned to exercise twice per week, kind of according to those guidelines that we discussed before, and the other was just a normal group that didn't exercise. And they found that the exercising group had reduced pain scores both at 3 months and after 12 months of exercise. So as we kind of wind down here, one of our last couple topics is poor appetite. So just to briefly discuss some terminology, anorexia is loss of appetite or having reduced calorie intake. Cachexia is muscle loss that's secondary to having a specific disease, such as cancer, where sarcopenia is a muscle loss that's related to being of a more advanced age. So there are numerous causes of having a poor appetite, and whenever you can identify one of these things, then you would want to kind of pinpoint on it and kind of treat whatever that specific cause may be, whether it's nausea and vomiting, constipation, or oral candidiasis. So this is kind of that thrush that I was talking about before, or that fungal infection, which can occur at the level of the mouth or throat, and it kind of presents as these like little white plaques like on your tongue or in your mouth. If your depression and anxiety can also cause someone to eat less, as well as pain with swallowing, particularly for patients with head and neck cancer or those undergoing radiation near the mouth or throat area. And altered taste also is a really big one, particularly for patients receiving radiation in the area of the mouth or throat. So these are all things that can contribute to someone having a poor appetite. So these are some strategies from the National Comprehensive Cancer Network for weight gain for those who are losing weight and really do have a poor appetite. So you really want to eat more often. You want to make sure that you're eating food that's high in calories and nutrients. You want to avoid drinking while eating. And just the reason for this is because, if you're drinking a lot of fluids, then you won't be able to eat as much food. You want to address any physical, mental, social reasons that may be present for being underweight. And they also recommend that you see a registered dietitian. So for those who are experiencing altered taste, there are a variety of home remedies that can be tried. And these are basically things like doing like baking soda rinses or saltwater rinses, or eating something sweet or sour prior to meals. And it's also thought that really cold and sweet foods like ice cream or shakes are better tolerated for those with altered taste. So you really may have to try a variety of things. There's not a lot of evidence behind this, but they are simple home remedies that you can just kind of easily try. And if one of them is effective, then that's obviously really good. Dronabinol, there's a little bit of evidence showing that really low doses of dronabinol, which is medical marijuana, at 2.5 milligrams twice a day, can be somewhat helpful in helping with taste. And there's also a little bit of evidence, again, not a lot, showing that zinc supplementation at 30 to 50 milligrams 3 times a day can also be helpful in restoring appetite. But again, I'm not strictly promoting zinc supplementation for everyone with this problem. And I would advise you to talk to your medical team before starting on any kind of supplement, because they all have kind of side effects of their own. And we don't want anything interacting with any chemotherapy regimen that somebody might be on. And if kind of all those other methods aren't working, there are some different appetite stimulants that are available. There's honestly not a lot of great data showing that these are effective in actually leading to weight gain. But when I do start patients on these, they do feel like their appetite is better. So really common ones that we use include olanzapine, also called Zyprexa. We talked about this before when we were talking about nausea. So it's really nice in that it can help with multiple symptoms. Dexamethasone, which is a steroid, omega-3 fish oils, which is a supplement. Different kind of marijuana compounds have been shown to increase appetite. And another commonly used agent is mirtazapine, also called Remeron, which is actually an antidepressant. And again, this is one with multiple effects that can not only help with appetite, but can also help with sleep as well as mood. So if there's kind of a certain constellation of symptoms present, then this may be a good medication for you to try. So finally, the last topic that I wanted to go over is chemotherapy-induced peripheral neuropathy. So common symptoms that occur due to this include burning sensations of burning and tingling, cold-induced pain, particularly for patients who are on oxaliplatin, feelings of numbness, as well as loss of balance and difficulty walking. These chemotherapeutic agents tend to affect our nerves in what we call a length-dependent manner, meaning that the nerves that are kind of furthest away from our spinal cord are the ones that are affected the most. So these symptoms occur in what we call a stocking and glove distribution, primarily affecting the hands and the feet. So there's a lot of different kinds of chemotherapy that can be toxic to nerves, including everything listed here. And the rates at which these occur are actually quite common. So if we move on and look at this chart, we can see all the different kinds of chemotherapeutic compounds on the left and kind of the incidence rates at which they cause these neuropathy symptoms. And we can see that especially for oxaliplatin, that the incidence rates are quite high, 85 to 95%, and also with paclitaxel, which are both, both of these are really, really commonly used chemotherapeutic agents at 57 to 83%. So these are really common problems. I do want to touch really quickly on the coasting phenomenon. So sometimes patients will go through chemotherapy and not have any symptoms of neuropathy, and they'll feel completely fine. But after they stop chemotherapy, then either weeks or months later, they will start to develop neuropathy symptoms, and that sometimes can be attributed to this, what we call coasting phenomenon, which is basically when symptoms may not start or they worsen after you stop chemotherapy. So this is a study that they did showing basically worsening of symptoms as seen by the decreasing line here. And all this shaded area means that it's a time after chemotherapy has been stopped. And as you can see, patients experience worsening sensation symptoms even after they stop chemotherapy. So this occurs with platinum-based agents, including cisplatin and oxaliplatin. So if this is you, just keep in mind that it may be due to this coasting phenomenon. So a number of different agents and modalities have been used to try to prevent chemotherapy-induced peripheral neuropathy from occurring, including everything listed here. And some of these things people may recognize. However, I think it's important to note that the evidence to date doesn't really support the use of any specific agent for the prevention of chemotherapy-induced peripheral neuropathy. So this is the guideline from the American Society of Clinical Oncology. And basically all these different European oncology associations agree that as of right now, there aren't any agents that should be recommended strictly for the prevention of this kind of neuropathy. So what then can we do about it? Fortunately, if you are experiencing kind of what we call like positive symptoms of pain or discomfort, then certain medications can be used, including Neurontin, which is gabapentin, pregabalin, which is Lyrica, and duloxetine, which is Cymbalta. And for those experiencing problems with balance or their walking ability, then there are different things that can help with that as well. So the first thing I always counsel people on is you have to be just very aware now that you're not walking the same way anymore because your nerves have been damaged. So you have to be very aware and kind of looking down at where you're walking, and you want to be make sure that you're walking on even level terrain. You really want to be avoiding any kind of uneven terrain like, walking like on a hillside or walking like in grass where you like can't see holes or something like that. Physical therapy can be really helpful in kind of helping with balance. So in the same way that you can exercise your muscles to make your muscles stronger, you can also exercise your sense of balance to make your sense of balance better. And here on the right, we can see a physical therapist demonstrating some balance exercises. This is called the star excursion exercise. There are some foot orthotics. Again, not a lot of evidence behind this, but some people feel like it does help. This is a metatarsal pad shown here. You can get these off Amazon for like $10 or $30. The idea is that it kind of provides increased sensation to the foot. So you kind of have a better idea of where your foot is, which can kind of help with balance. And if those things aren't working, or if you're having a lot of difficulty with your balance to the point where you're fall risk, then we do recommend the use of assistive devices such as a cane. So that's pretty much everything I have. I'm not sure how much time we'll have for questions, so please take note of my contact information. This is my email address. This is my office number. Please contact me with any questions that you do have. We will get to whatever we can right now.
Dr. Chang, if you're available for a little bit longer, we can add a little extra time for questions.
Yeah, definitely. That sounds great.
Wonderful.
So the first question is about experiencing painful leg cramps at night with tamoxifen use, and just asking if there's any suggestions in mitigating those kinds of muscle cramps. So I'm not sure. So I would say that you would have to see what the muscle cramps are coming from. I'm not, I can't say if it started exactly after you started on tamoxifen, but there's a lot of reason for kind of painful cramps at night, like including restless leg syndrome or having low levels of electrolytes or kind of being dehydrated. So yeah, I would recommend that you would probably have to see a specialist and be evaluated kind of in more specific detail to see, kind of determine what exactly might be causing your leg cramps. Because that's not a usual, I wouldn't say that's a usual symptom from tamoxifen. Okay, so another question is regarding the use of certain medical interventions for night sweats. There's a lot of different kinds of interventions. So if it's specifically for hot flashes, night sweats caused by hot flashes, then there are a lot of things that you can do. I would say that kind of the most tolerable ones in terms of medical interventions that have fair evidence behind them are the use of magnesium supplements, typically magnesium oxide, 400 milligrams daily, and sometimes you can increase up to 400 milligrams twice a day as needed. And gabapentin, typically at doses of 300 to 600 milligrams 3 times a day, have also been shown to help with night sweats that are secondary specifically to hot flashes, if that's what the question's asking. Next question is, does neuropathy continue for years after chemotherapy is over? So this is a really good question. Basically, most patients will experience relief of their neuropathy and they will have improvement in their symptoms after chemotherapy is finished. That said, there's a smaller subset of patients in which neuropathy symptoms will persist and really be permanent and irreversible. So for some patients, yes, it can continue for years after chemotherapy is over. Is regarding constipation. And it's basically asking, someone's been using Miralax and Colace as they've been dealing with constipation for a long time, and they've been using it for a matter of years since surgery, and they're asking if that's okay to do. So Miralax, there have been some longer term studies. And when I say longer term, I mean like in the area of months, showing that it's okay. and it hasn't really been causing any problems. Colace I'm not aware of, but it is very commonly used, and some people do take it for months or even years. So I would say that it's yeah, I think that it's as long as it's not giving you any problems and you're not having any like increased frequency or loose stools or bloody bowel movements, I think it's fine. So what I kind of always tell people who are on these medications for longer term is that in spinal cord injury patients who have kind of lost all their reflexes down there, we do prescribe these kinds of, they're on these kinds of medications, sometimes for the rest of their lives. So I would say as long as you're not experiencing any ill side effects from it, then I think it's okay. Next question is asking to repost the website with the guide for the wrist massage to reduce nausea. Let me click back to that slide. And then you could maybe write it down or go visit that website right now. Okay, hopefully you can see this. So there's the website right there. Are there any biofeedback methods that you have found to be effective in treating side effects of chemo? So I guess it depends on which side effects you're referring to. In terms of, I guess when I think of biofeedback, I typically think of things like either electrical stimulation biofeedback or manual biofeedback provided by like a physical therapist or an occupational therapist. What I can tell you is in regards to specific physical modalities in treating side effects of chemo, there is pretty good evidence for the use of acupuncture in helping with side effects ranging from nausea to chemotherapy-induced peripheral neuropathy. What can be done about darkening cuticles? And what about crusty eyes with secretions on the eyelashes? That is a very good question. I'm honestly not sure about that. That's a little bit outside my area of expertise. I would recommend that you probably start by seeing your primary care provider, who may refer you to an ophthalmologist if indicated. But if you're having significant secretions around the areas of the eyes, I think it would be wise to maybe consult a specialist just to make sure that there's no kind of infection going on, particularly if you're on any kind of medication that could be causing immunosuppression. Next question. So it's basically asking, so it's kind of stating that reading is good before you go to bed. And it's asking if there's like a difference between using a Kindle versus physical books. So I think the question here is being asked about like blue light. So my understanding is, I guess it depends on what kind of Kindle it is. If it's like one of those tablet Kindles that, has like the really bright lights, then that's probably not great. If it's like one of those Kindles where it's just like, I think the e-ink that kind of resembles a book, I think that would be fine. That said, there are also special kinds of glasses that you can get that kind of, I think those are like available on, you can get them like off the internet too, but that kind of, they're supposed to supposedly block out kind of blue light. But my feeling is, if it's a typical Kindle with ink, then it's probably okay. Okay. One question is, any thoughts on persistent abdominal pain? So it really depends on what the cause of the pain is. I would recommend that you be evaluated by a specialist who can try to determine what the cause of the pain is. So for instance, if it's something new and severe, I mean, it's possible that you may need to get imaging to see if there's anything going on there in the area of the abdominal, the area in the abdomen, the pelvis. There's a lot of different things that could cause pain, whether from the intestinal tract or reproductive organs in that area. So you would kind of want to make sure that you rule out anything serious going on. If we're talking about more kind of persistent pains in the area of the abdomen that are occurring after surgery. Depending on the kind of surgery you received, it is possible to get kind of nerve mediated pains. Sometimes it just kind of depends on what kind of surgery you had. There are some treatment options available for that, typically nerve blocks, and depending on which nerves they are, you can get ablations, which can sometimes provide more longer lasting relief. And then there are kind of different kinds of oral medications that can be used depending on the kind of pain it is. Okay, so this is actually a comment of someone just sharing that, when they were experiencing kind of those aromatase inhibitor joint pains that we were talking about, that once they started swimming again, it took the pain away, and they are highly recommending water exercises since they're non-impact, and I 100% agree with that. I think that's a great recommendation. Another question regarding coasting phenomenon. How long pain with neuropathy can be expected to last on average? So kind of touched on this a little bit earlier, but in a smaller, so most patients will get better and most patients will have improvement, but there is a small subset of patients who will kind of have persistent symptoms that will be permanent. So what I generally tell people is nerves take a really long time to heal. So nerves basically heal at a rate of like 1 millimeter per day. So if it's been, we would kind of expect you to be better generally like within 1 to 2 years after finishing treatment. If it's been like 2 years since you finished chemotherapy and the neuropathy symptoms are still present, then they're likely they're unlikely to resolve. Is CBD helpful in managing neuropathy pain? So either topical or ingested CBD. Another really good question. Yeah, CBD, it seems these days, is having a lot more use for a variety of different symptoms. What I can say is it's not something I necessarily go to as a first-line treatment, and in the treatment of neuropathic pain, based off of like treatment guidelines for neuropathic pain, I don't believe medical marijuana is even a first, second, or third line agent. It could possibly be, I think it might be a fourth line agent. That said, I have had patients who, get topical CBD and, use it, on their hands and their feet. And they swear by it. And I had one patient who I tried a number of different things for, a number of different medications, many of which I talked about during this presentation, and none of them helped him. And then he said that he just rubbed CBD. I think it was like a CBD oil, like on his legs, and it like cured his neuropathy pain. So I would say, yes, it probably definitely can be helpful in some people in managing neuropathy pain.
Thank you so much for joining us today, Dr. Chang, and for giving us such wonderful information. It's been such a pleasure.
Yes, thank you so much for having me.
Have a great day.